Three,
There's
two,
some
one. We are live now.
Okay.
Thank you. So, welcome to the platform of Orthopedic Research and Education Foundation India. Today, we have our chairman, Dr. John Mukhopadhaya, sir, who is teaching us about surgical tips and management of periprosthetic fracture. Over to you, sir.
I'll just share my screen. You see that?
Yes, sir.
Okay, so welcome full screen. So is that okay?
Yes, sir.
So today we are going to discuss periprosthetic fractures. Is this a bit too big or something, or it's okay?
It's okay, sir.
Okay, then.
Yes.
Okay, we're going to talk about periprosthetic fractures, and the learning outcomes for this are that we should appreciate the enormity of the problem. We need to be able to assess these clinically and radiologically. We should be able to classify these fractures and then discuss the principles of management. Now, periprosthetic fractures are really the next epidemic for the orthopedic surgeon. I think we've been through the hip fractures, the osteoporotic fractures of various parts of the bodies. And now, with the increasing number of arthroplasties being conducted worldwide, along with the increased longevity of patients with the resultant osteoporosis for various reasons apart from age, and some of these fractures may also be related to the technique. So they may be to some extent iatrogenic. The other problem is that conservative treatment is rarely an option because these are mostly elderly patients who you want to get up and about early. So usually it does involve either fixation or a revision prosthesis for many of these patients. So there are multiple challenges to the management, including the fact that because these are elderly patients, they have multiple comorbidities. You have the presence of the prosthesis, which makes the fixation difficult because there's a limited amount of bone for your fixation of the fracture. Very often, intramedullary nails will not be an option. The bones are osteoporotic again, so the hold of the screws or purchase of the implant is not as good. And you may also have ligamentous disruptions in this situation, which make it even more difficult. Now, there are various factors which may be classified as mechanical factors and patient factors. The mechanical factors are the loosening of the implant, the osteolysis, and possible notching in a total knee replacement. And the patient factors are problems such as inflammatory joint disease, chronic steroid use, which makes the bone osteoporotic, neurological disorders, which can create problems of balance, which lead to falls and hence fractures. Somehow it seems to be more common in the female gender with age. And the goals of treatment are always the restoration of function. Okay, now to get restoration of function, you have to get the fracture to unite. You need to be able to preserve the prosthesis where it's appropriate. You need to avoid infection in your surgery. You need to maintain the alignment of the bone if there's a fracture that you're going to fix. If you fix them in a malalignment, then it will affect the prosthesis. And you need to try and restore a range of motion, which makes life possible or less difficult for the patient if they have a good range of motion. Now, your decision making really has 3 or 4 things to look into. One is the stability of the fixation of the implant, the general condition of the patient and any such comorbidities, the life expectation, which is again related to the general condition, the age and comorbidities, the bone stock, which is related to osteoporosis, and sometimes disuse, etc., which may happen. So, where possible, it would be useful to know the function before the fracture. So what was the patient's condition before this fracture happened? Was he or she completely mobile? Was there any pain? Do they have any x-rays which were done recently before the fracture took place? Because some of these arthroplasty patients, they get their arthroplasty done, they may come for 1 or 2 follow-ups, and then because they feel okay, they don't come back again for many years. And then suddenly the first time you see them is when they've had the fracture. Now, coming to the classification of these fractures, in the past, we've had classifications for various fractures around various prostheses. So the most useful one of these was that which was known as the Vancouver classification for fractures around a total hip replacement, especially femoral fractures around a total hip replacement. And they were then classified into the location of the fracture, the fixation, and the quality of bone stock. So A was a fracture which involved the apophysis of the bone. That means it could be the greater trochanter or the lesser trochanter. B was through the bed of the implant. That means the area of the implant where the implant was fixed was involved in the fracture. And C was when the fracture was clear from the implant. So you had total hip replacement of the hip, but you had a fracture distal to the stem, maybe a part of the distal femur or shaft of femur, which was really not directly in contact with the arthroplasty. Okay, the next thing was whether the arthroplasty was fixed well or not. Now, if the fracture went right through the entire fixation of the prosthesis, especially if it was a cemented prosthesis, if even a part of it was really involved, very often the implant would be loose. Sometimes the implant may have been loose previously. I mean, this is where the history or any previous x-rays become useful. And then you need to look at the quality of the bone. Now, if the bone quality is good, then you know your implants will hold well in that bone. Where the bone quality is poor, it would be a B3. That means the quality of bone is not so good, and you may have problems with your implant holding. So this is especially for the B-type fractures, which could be B1, where your fracture was in the bed of the implant, but the implant was well fixed. B2, where the fixation was compromised because of the fracture or before the fracture. And B3 was a fracture with a sort of compromised fixation and also poor quality bone. So similarly, for the distal femur around a total knee replacement, you had the Rohrabeck classification. Okay, so here you had type 1, which was undisplaced but with a stable prosthesis. Type 2 was displaced with a well-fixed prosthesis. And type 3 was displaced with a loose prosthesis. So again, the fact that whether the prosthesis was fixed well or not affected your treatment plans. You also had a separate fracture where you had a proximal classification, where you had a proximal tibial fracture around a total knee replacement. So these were the one most commonly used was that by Felix et al., which looked at the anatomical the region of the fracture or anatomical location of the fracture, the fixation of the implants, and the timing of the fracture. So whether this took place intraoperative or postoperative. Now, because there were separate classifications for separate parts and separate prostheses, there was this attempt to try and bring about a unified classification system. And this was by bringing the Vancouver classification to the other fractures around other bones and joints involved in periprosthetic fractures. So the unified classification system was developed with a mnemonic where A remained the type A, which was the apophyseal fracture. Type B remained the type B, which was through the bed of the implant, irrespective of where the implant was. So if it was around the knee, it would be the femoral component, or around the tibia, it would be the tibial component. The femur would be, femur in a total hip would be the femoral component. The type C was where it was clear of the implant. Now, type D was where there was a hip replacement and a knee replacement, or a knee replacement and an ankle replacement, and the fracture was in between the two implants, two arthroplasties through the bone. So it was type D, was called dividing the implants, again to keep the mnemonic growing. Then type E was each of the two bones around a prosthesis, around an arthroplasty. So if you had a total knee arthroplasty, a fracture of the distal femur and the proximal tibia, or the femur and the tibia around the knee, would become a type E type of fracture. Similarly, if you had a total hip, a fracture of the femur and an acetabular fracture would become a type E type of fracture. And type F was facing the implant. Okay, so this was, say, in a total hip replacement, you have a acetabular fracture only, then it becomes a type F fracture or periprosthetic fracture, where you have the fracture of the acetabulum, which is facing the implant. So it could happen, say, in the ankle. If you have a talus fracture, you could have a calcaneal fracture. It would become a fracture facing the implant. Okay, now the type B, as usual, as in the Vancouver classification, need to be subclassified. The B1 being the implant was well fixed. B2 was the implant was loose, but the bone quality was okay. And B3 was the implant was loose as well as the quality of bone was poor. So that is how you classified it. So if you had a type B, you can see this is a uncemented prosthesis. Although the fracture is through the bed of the implant, the prosthesis was well fitting in the proximal part, and your main problem was to get the fracture to heal. Now, in a cemented implant, where you can see the fracture has gone right through the bed of the implant, from extending from the region of the neck to the shaft just distal to the femur, you know that this is a implant that is loose, and you're going to have to revise the implant as well as deal with the fracture. And type C was where you have a periprosthetic fracture and the quality of bone is also very poor. So here's an example of a type C, where you can see that the fracture is away from the implant. So although the implant is in the proximal part, it's a reasonably well fixed implant, but the fracture is distal. So you just need to fix the fracture and not worry about the prosthesis at this stage. Now, your treatment would also depend on certain factors, including the fracture related, the patient related, and bone related fractures. Okay, so your indications for revision or osteosynthesis would depend on the stability of the implant. If the stem was well fixed, as I mentioned earlier, you would plan for an open reduction and internal fixation. If it was a B2, that means the stem was loose, you would revise the prosthesis along with doing something for the fracture. And if it was a type 3 or B3, where the stem was loose and the bone quality was very poor, you could think of either something like a substituting proximal femur prosthesis. That means it was almost like a tumor prosthesis, which would only hold distally. Or you could think of augmenting your fracture fixation with things like strut fibular grafts, etc. So I think this is in a nutshell how you would plan your treatment for any periprosthetic fracture. Of course, the type of implant may change how you manage it, like especially in a total knee replacement. There's some knee prosthesis where the femoral component will allow you to use a distal femur nail, and others which make it difficult for you to. So the cruciate retaining ones can usually give you enough space to put in a nail, while many of the cruciate substituting prostheses make it difficult for you to put a nail through the implant without any problems. Okay, and so basically, if the prosthesis is loose, you also need to replace the implant. Of course, there are some few sort of reasons why you may not in a particular case, but by and large, wherever it's loose, you would have to also change the implant. So coming back to that case which we showed earlier, which was a B1 type of fracture around a hemiarthroplasty. This was then fixed with a plate. Okay, so you use a long plate, you use cerclage wires in the region of the prosthesis because there your fixation is compromised, but you use multiple screws plus cerclage to give you a good hold, and you put screws on the distal fracture, use a long plate, leave a few screws free, holes free, and you can see how this has gone on to heal well, and his prosthesis is fine and is no problems at this stage after this fracture has healed. On the other side, this was the other case which we showed where you know that the prosthesis is loose. You would have to do something like a distal hold stem with wiring for the fracture. So this was a solution stem, long solution stem, going through the fracture area, holding on to the bone in the distal part and wiring for the fracture along with the prosthesis, keeping the fracture stable and allowing it to heal. Okay. Now, so we've done a fair number of hips. Now it comes to the fractures of the distal femur around a total knee replacement. Okay, now here there was a trend to treat some of these non-operatively with things like cast or brace, but generally you want to, like I mentioned, we want to get these patients up early. So generally we would think of internal fixation. Okay, so there have been studies which have shown that surgical treatment is better. Like I mentioned earlier, cruciate retaining knees have open box, which allow nailing, which is possible. Other fixation options are like conventional and locking. So here's a patient who had a total knee replacement. This was PFC type of implant, which has a closed box. So here we have to think of plating it, although nowadays with the newer nails, it may be possible to nail them. But one of the things which I have noticed is many of these distal femur fractures tend to be oblique with a more distal fracture on the lateral side and a more proximal fracture on the medial side. Now, this makes it almost important to actually buttress that medial beak, and often this is posteromedial, okay? So you may have to buttress this and then use a long bridging plate on the lateral side, something like that, and you can see how this has then gone on to heal well. Okay, so you can see it's a posteromedial plate. Here's another patient, similar type of fracture. Again, you can see that the medial side fracture is more proximal, the lateral side fracture is more distal. These are the CT scans just to... Can we stop the noise, please?
Yes, sir. Just check.
You mute everybody else.
Yes.
Okay, so this is the fracture. So that just is a short video showing you that the implant is stable. Okay. I think you need to get rid of that noise in the background.
Yes, sir, I'm trying, sir, actually. It's not... Maharishi?
Just mute everybody else.
Actually, yes, sir. Actually, I have no control because...
Yes, sir.
Just mute. Make me co-host right now.
Yes, sir.
Ask him to mute everyone otherwise. Is that okay?
Yes, sir. Yes, sir.
So here you can see how we have gone to the posteromedial aspect using a subvastus approach and buttressing the posteromedial beak after having temporarily reduced and fixed it with K-wires. And then we put a long lateral plate. Now, because these bones are very often curved in the elderly, you are allowed to bend these plates slightly. Not a lot, but a little amount of bending is possible. So that's the shape of the plate once you've done your bending. And you can see how now this sits nicely on the fracture and it is fixed with a posteromedial buttressing of the fracture and a long lateral plate, which will give you a good stable fixation and allow you early mobilization. So here's another patient who had this fracture, again treated similarly. You can see a long lateral plate, a posteromedial buttressing of the beak of the fracture. Again, you can see the fracture medially goes more proximally than the lateral side, which is more distal. And again, you can see how this is going on to heal with time. This is an interesting case which was actually done in our own hospital. So she had bilateral TKRs, and a few days later she had a fall and she actually fractured both sides. So the right side was a fracture of the medial epicondyle. We could fix it with a screw with a washer, spiked washer, and a buttress plate, and that was okay. But on the left side, you can see that the joint was totally loose. It came out, and we had to actually revise it with a revision prosthesis. So I think these fractures can cause a number of problems. Now we're coming to the tibial side in a total knee replacement. So some of these fractures could be minimally displaced or undisplaced. In this case, you can just about see the crack. And some of these could be treated conservatively. But again, an elderly patient, we want to get up quickly. You need to fix these. And we ended up having to put a buttress plate on the medial side. Again, it would be useful to have polyaxial screws to avoid the peg where you can, and this buttress plate then went on to heal well. So the CT scan just showing you the fracture because you could hardly see it without the implant. And there's another, and this is post fixation. This is another interesting case who earlier had a femur fracture which was fixed after a knee replacement and then developed a total fracture of the tibia. So here you can see it's a complete fracture. It's displaced a bit. You can see the angulation. And in this situation, you have no option but to go ahead and fix it. And you need to get a good stable fixation. And because the short segment proximally also has the stem of the knee replacement, it makes it a little difficult to get adequate hold. You can see the CT scans here just to make sure that the prosthesis is okay. You tend to get a CT scan to look at not just the fracture, but also the fixation of the prosthesis. And here we used a dual plate, again, using polyaxial screws proximally so we could go right across the proximal tibia and also buttressing the medial side with a plate so that we can start mobilizing these patients early. Sometimes you can get stress fractures in some of these osteoarthritic patients because of the varus. And this patient actually had a fracture on both sides. She had a total knee replacement with a long stem on one side, but on the other side, for some reason, it was decided to fix the fracture with a plate and then do a short stem. And then this is what happened. She broke at the plate and at the fracture level, and the plate broke. And this is how she came to us. And here we had to then put a revision fixation of the plant. We also did a fibula osteotomy, and this fracture then went on to heal. Last, we come to the patella, which is around which is a fracture where you need to really look at the extensor mechanism, because if that is disrupted, you need to do something about it. Also, if the patella has been replaced, it makes life a little more difficult. If the patella has not been replaced, you would treat it like a standard patella fracture and fix it with wiring. But if the patella button has been replaced or patella has been replaced with a patella button, it makes life a little more difficult. So the integrity of the extensor mechanism in the patella is one thing where you can treat it with fixation, but if it is at the tibial tubercle or of the tibial of the tendon, then it becomes more difficult. And there you have to think of various reconstructive methods, including tendon grafting, to keep the fracture well, to treat the periprosthetic fracture. Okay. Now, where this is an example where a patella fracture which was displaced. Sorry that this is coming right there. The proximal part of the fracture you can see is grossly displaced, and here you're sure the extensor tendon mechanism is disrupted, and so you have to fix this. You can use a standard tension band wiring for these fractures. So here we did a standard tension band wiring. Removed the wires after some time because the wire was irritating her, and then she went on to do well with a good function. You can see she's got almost a pre-operative range of movement. Sometimes, even if the prosthesis, you're not sure about the prosthesis, you may decide to fix a fracture because of the condition of the patient. And this was a patient with multiple comorbidities. She was on dialysis alternate days. She had severe diabetes. In fact, when she was admitted, her blood sugar was well over 500. And we just got her sugar controlled and then went ahead and did a long fixation with wires. And you can see how we were able to then mobilize her fairly soon. She continued having her dialysis, but she recovered from the surgery and went home. Again, we are getting some.
Yes.
Okay, so last case where just to show how this problem can keep repeating itself. This is a relative. He was a 24-year-old when he came with ankylosing spondylosis. We did his left hip replacement, did well, was fine with that. Then we did his right hip replacement. He was okay with that. And then he had a fracture which was at 13 years or 14 years after the second replacement on the right side, which was treated somewhere, but this plate kind of stopped just distal to the fracture. And then he re-broke the femur and came to us. This is what he came to us. So we fixed it with a plate on the slightly anterior side because we wanted to avoid the fixation of that side. Okay, but this broke again. We fixed it again with a longer plate. He came back with a revision with another fracture. Those were the CT scans. He also had a fracture on the opposite side. Okay, if you can see the opposite side, that is also fractured. This is the left side, right side also fractured. And then we had to fix both these fractures. The left with a long plate, that was, and the left one was the hip, which was done way back in 2000, was still going fine. There was no problem with the hip. And the right one, which was done a bit later, was the one which had multiple fractures. To the right side, we then removed the implant, freshened the bone ends, and refixed it with 2 locking plates, interfragmentary screw and bone graft. And then finally, we were able to get both the fractures to heal. Hopefully, he doesn't come back with another fracture in the near future. But it's a matter of time when these things keep happening. And this is why I say this is the next epidemic for the orthopedic surgery. To take home, I think these are challenging problems. You have to really assess these patients very carefully. You have to take the general condition of the patient, the stability of the implant, and the quality of the bone all into account when you plan your fixation. Thank you. And I'm happy to take questions.
Thank you very much, sir. So while we are waiting for the questions, sir, The one thing, sir, in type C fracture, like after THR in femur, is that management is almost same as the normal femur fixation, or is it
No,
different?
it's different. I mentioned that you have to very often either augment your fixation with things like fibula graft, or you may have to revise to a replacement of the proximal femur in a total. So you do something like a tumor prosthesis so that the osteoporotic fractured part is substituted with the implant. Okay.
So bone quality we should take care of
Yeah. So
while
no, you are.
fixing.
So you have to look at the implant, the fracture, the fixation of the implant or the stability of the implant, and the quality of bone, apart from comorbidities of the patient, into account when you're planning the treatment. Okay.
And sir, about the management of type E fracture, if it is
Yeah.
on either side, uh, so we should manage it like which type it is according to
Yeah. So
that part.
each component has to be managed separately. Okay.
Okay, sir.
So if the femur and the tibia, now the problem comes in some of these very old implants because you have a loose uh, prosthesis on one side, but you do not have that prosthesis available anymore. Okay, so there you become, you are either have a choice of replacing both, okay, because you can't just revise one side because the other side will not fit because that particular implant is no longer available. It happened to us recently, I mean, not recently, a few years ago, with a patient who we'd actually treated her femur, a tibial fracture, and the next time she broke her femur, but the femoral component was also loose. But there was that implant was no longer available. So, and in trying to get the prosthesis, it took so much time that the patient was waiting for a long time, was beginning to lose her patience. And I think she finally went to Delhi or Calcutta to get her revision surgery done because she couldn't, because they weren't being able to provide us the prosthesis on the dates they would say. So they would say one day and then that day the implant would not arrive. So I don't blame the patient for losing patience and then going somewhere else.
In any case, we may need to fix a loose prosthesis, sir, or is it always to remove it?
I think I mentioned these things in the talk. Um, in almost it, if you you're sure the prosthesis is loose, then ideally you should change it. But sometimes the patient's condition is such that to do that would be a very high risk. So you may decide to just fix the fracture, get the patient going, and then deal with the prosthesis later. So someone's got a stem which is possibly affected by the fracture and you're worried that it may be loose, but the general condition is poor, then go ahead and fix. Because if you want to revise that, it'll be a very long stem, complex prosthesis. While if you can get the fracture to heal, you can then revise it to a relatively simple revision. Okay, so you have to make a decision based on that. You need to talk to the patient, tell them that yes, we are doing this, but you're going to need a revision of the hip once you settle down from the fracture or once the fracture heals. So I think that's a call that you have to take along with keep taking the patient or the patient's attendance into confidence.
So that may be in the two stage if it is we need to
Yeah,
change.
it's so it could be where you're sure, unusual where you're sure it's loose. Sometimes when you're not sure, you may decide to fix it and then see what happens, and then but you need to warn them because very often when you have a fracture, the risk of the prosthesis also being loose is quite high. Okay, so sometimes it's very difficult to tell straight away. So you may decide to fix the fracture, If you see the arthroplasty patients, surgeons, they'll probably replace every other periprosthetic fracture. We tend to try and fix more than directly replace the prosthesis where possible. But if it's obviously loose, you have no choice.
So I think other than uh, B2 type, which is quite confusing, in B1 it is okay to fix, and in B3 it is usually to replace, ideally.
Yeah. So B2, so B3, yes, but you need to take the patient's comorbidities into
Yes.
account.
And
B1, the fixation can be difficult, okay? Because if you have a prosthesis proximally, you're limited with the number of screws and wires you can use. So your hold may not be that good, and that's why fixations fail. So you have to make sure that your fixation is adequate. You have to make sure there's no stress concentration on the implant. So you have to, depending on whether you go for a absolute stability or relative stability, you have to plan your implants in such a way that they will be able to hold the fracture till it heals. Okay.
so this one last question, sir. In case of distal femur periprosthetic fracture, I have seen in most of the cases you have used two plates. So is that is always necessary, sir, or
So I no. So if you saw one case where the patient came with a tibial fracture and we had fixed the femur earlier, we had used a couple of lag screws, and because the fracture was more proximal. Now, when the fracture is very distal, usually have very little bone, which is further compromised by the prosthesis, cement, etc. So your hold in the distal fragment is very limited unless you use a second implant. Okay. Also, very often, like I said, the fracture pattern is such that you have a posteromedial beak, which you can buttress nicely with a short plate and then put a long plate on the lateral side. So I think you need to look at all this. Today, the nails, there are some new nails which are available, which have different bends, curvatures, which it may be possible to use, because what happens is with the femur component there, even if it allows you to put a nail, very often you have to start a little more posterior than you would start otherwise. Okay. Now, if you start a little posterior, you need to have a bigger bend in the nail to be able to, otherwise it'll send the fracture into extension. Okay. So I think these are the things that you have to look at. So nailing is becoming more popular, or combinations of nailing and plating. Just as we do two plates, you can use a nail and a plate to give you more stability to allow the patient to move early. But you have to have the right nail and the right knee implant to allow you to do that. And the right fracture for that, because if it's very distal, it becomes very difficult. Okay.
I think if delegates have any other question, please ask right now. So thank you very much, sir.
Sure.
It was great hearing
Thank you.
from you, learning again.
Yeah. Okay. I think we need to do something about the noise. There's too much background
Yes,
noise.
sir. Because initially I do not have control, and it is just 1 or 2 person who
Yeah,
has.
it needs only one person. That's
Yes, sir.
so you need to make sure that the others are muted. And this,
Yes,
I mean, it's okay for me, but when you have other people guests speaking, it becomes
yes,
very disturbing. So you have to make sure you have the control and mute everyone else till the question
yes.
answer session. Okay, great. Bye.
Thank you very much,
Bye.
sir.
Thank you. Bye.